Dr. Rathod, who's going to be first talking to us about can diabetes affect your eyes. Dr. Rathod, you have our attention.
Good morning, everyone. Thank you for coming on this lovely Saturday morning in Orange County, home for myself also. I want to thank Donna and Dustin and folks at the Macular Degeneration Association for hosting these events. I've been doing this for quite a few years now with the group and done many talks across the country. It's nice to be able to do one at home in our backyard. First, just a little bit about myself, Dustin. Thank you for the kind introduction. My group is local here. We're at Orange County Retina. We're all a group of retina specialists. We have 5 locations in Orange County, all throughout the county. We focus specifically on retinal diseases and treatments, in-office and surgical treatments for retina conditions, including macular degeneration and diabetes, which we'll be talking about today. In the back is Annie Domingo. She's our marketing representative, and she's happy to answer any questions about the practice if you have any. And one of our technicians, Dr Rathod, is also here, who's going to be applying to medical school and taking my job in a few years. So I just wanted to introduce those folks also. So welcome again. This talk, I have some slides. I'm going to go over the slides. The first one is on diabetes, but this talk and presentation is for you guys. It's for education and knowledge. Feel free to ask questions if you don't understand something. If you want to know something more, feel free to stop me, raise your hand, and I'm happy to take questions. And we can also make this somewhat interactive. First, we're going to talk again about diabetes, a very common condition that also has consequences for the eyes, and specifically on the retina, which is why we talk about this, and we have a lot of patients who we treat for diabetic retinopathy. So let's just start with some very basic information. So what is diabetes? Again, diabetes is a group of diseases that's generally characterized by high circulating blood glucose levels. So your blood glucose levels are higher than they should be, and this can happen for several reasons. Either a problem with production of insulin or a problem with responding to insulin in the body. And so insulin is what helps to regulate blood sugars, and if your insulin levels are off, then your blood sugars will rise abnormally. And so that's the underlying problem with diabetes. And there are many different types of diabetes. The two most common, which we typically consider classified as type 1 and type 2, they actually now have 5 different categories of diabetes that they recognize, but the most common, again, being type 1 and type 2. Type 1 is the one that we consider juvenile, typically diagnosed at a younger age. This only affects about 5% of the diabetics total, but this is generally more of a genetic thing where your pancreas doesn't produce adequate insulin. And so that generally starts at a very young age. Type 2 is a much more common one, so what most people have, and this is often develops later on in age and is a result of abnormal sensitivity to insulin in the body. So those are the 2 most common types. It has a huge impact on our healthcare system and our health in general. In the U.S., about 26 million people are diagnosed with diabetes, and it's about probably now close to 300 million worldwide. A lot of people are undiagnosed. A lot of people walk around not knowing that they have diabetes, their sugars are elevated, that they're sustaining damage to their organs. And so there's a large category of people that are in this pre-diabetic category also, where their sugars are high, their A1C, which is one of the markers we use for blood sugar control, may be in that middle range where it's considered higher than it should be, but not quite high enough to need medication. If we look at everyone over 65, 1 in 5 people have diabetes, so very, very common. And the prediction is that of those that have been born since 2000, 1 in 3 people eventually will have diabetes. So the numbers are on the rise. It's a big problem for the healthcare industry, costing upwards of $130 billion annually in healthcare costs just for the diabetic care. And you guys hear about all the new medications and things that are coming out. The GLP-1s, as they're called, Ozempic, is a big buzzword nowadays. So there are obviously a lot of folks paying attention to better ways to treat and manage diabetes because of the prevalence and the cost to the healthcare industry. So how specifically does diabetes affect the eyes? Because that's what I deal with. Well, it can do a lot of things to affect the eyes. It can change the focusing, can lead to cataract formation, and can also lead to glaucoma. And then most relevant to what I do is the retinopathy aspect of it. So when diabetes is much further advanced, it starts to have an impact on the retina itself. And how do these changes come about? And what causes your vision to be affected when you have diabetes and your blood sugars are out of control? So if your focusing changes, so when your blood glucoses are elevated, the natural lens of the eye can get swollen, and that swelling causes it to change shape. And so, of course, if the shape of the lens of the eye is altered, then your focusing ability is altered also. So that's sort of one of the first things that happen, and one of the basic outcomes of having elevated blood sugars. Cataract development, diabetics tend to develop cataracts sooner than the average population, and that's just from the stress of having elevated blood sugars in the system. Oxidative stress in the body causes changes, including cataract development. And then diabetic retinopathy, again, when the diabetes is further advanced, it affects your retina, and this is worldwide the leading cause of blindness in people in the working age in industrialized countries. And it's estimated that close to 2 million people will sustain blindness as a result of diabetic retinopathy, and this is worldwide. If you are diabetic, you're 25 times more likely to sustain blindness than the average population. So obviously there's some serious impact on the eyes and the vision that we have to be aware of. If we look at how many people actually have diabetic retinopathy, so this is when you've gotten to the stage where you've been diagnosed with the disease of the retina due to diabetes. Over 7 million people in 2010, by 2030, which is coming up on us in a few years, over 11 million people. The numbers just keep rising. They estimate by 2050 over 14 million people. And this is patients over the age of 40 in the United States alone. So quite a common disease. What happens with diabetic retinopathy when it starts to affect your vision? In the early stages, you might not even be aware of it. So you might not have any effect on your vision. And then, things can start to just get blurry, generalized blurriness, having trouble focusing up close and reading, and then later stages starting to develop floaters or spots in your vision, and then very, very late end stages, it could lead to actually a red and painful eye, and that's one of the later complications of diabetes. Diabetic retinopathy at its basic level, again, because of the high blood sugar levels in the blood circulation, it causes damage to the blood vessels. So the blood vessels don't like having high levels of sugar circulating, and that causes some damage to the cells in the blood vessels. And when they get damaged, it leads to bleeding, it leads to aneurysm formation, and occlusion of the blood vessels. And those are sort of the ways that your blood vessels get damaged and affect the organs. And the blood vessels in the retina are extremely small and very delicate and very sensitive to any of these changes. And obviously any effect on the circulation and oxygen delivery to your retina will have an effect on your vision. So this is one of the first places that we see these changes manifesting in the body, but the same things are happening in all of the organs where there are small capillary vessels, including the kidneys, the heart, the brain, your nerves at the end of your fingers and toes. That's why you develop neuropathy. So it's all the same underlying problem with the circulation of blood vessels that leads to damage that then leads to problems with sight or kidney damage, etc. So when we do an evaluation for diabetes, we start off with a full examination. We use other diagnostic modalities, including imaging of the retina, to evaluate whether there is any diabetic retinopathy, the extent of the retinopathy, and whether or not treatment is necessary. We classify diabetic retinopathy into some basic categories. Either there's no retinopathy, or there's what we call non-proliferative retinopathy or more advanced proliferative retinopathy. And each of those are categorized into mild, moderate, and severe. So we have some subcategories. And those are just useful for us for knowing if treatment is necessary and how often somebody needs to be followed to look at their progress to see if they're developing any further complications. We also look to see if there's something we call macular edema. Macular edema is when the center of the retina gets swollen as a result of diabetes, and this can be in any of the categories, whether it's proliferative or non-proliferative, and that's another subset of diabetic retinopathy that we treat regularly. An advanced category where your retina actually can potentially detach. That's one of the further advanced complications of diabetic retinopathy, so that's another classification. So this is a sort of an image of what it looks like to have non-proliferative retinopathy. We see bleeding in the retina, we see small occlusions of the nerve tissue, microaneurysms, we see changes in the blood vessels. Those are all the things that we commonly look for and evaluate in diabetic retinopathy. Microaneurysms are one of the earliest signs. That's when the small blood vessels of the capillaries start to get damaged. As I mentioned, we subcategorize into mild, moderate, and severe, depending on what we see. Proliferative retinopathy is, again, much more severe form where what happens is because your tissues are starved for oxygen, there's a signal that says, I need more oxygen, and thus grow some new blood vessels to supply that oxygen. Well, those new blood vessels that start growing are abnormal and they're delicate and they shouldn't be there. And so they tend to bleed easily, then they can lead to scar tissue formation, and that's when we see the retina can potentially detach. So that's something we absolutely want to try to avoid, seeing this new blood vessel growth. If those blood vessels do bleed, you can get what we call vitreous hemorrhage, where the whole center cavity of the eye fills up with blood, which potentially could require surgery to correct. And then very advanced form of retinopathy leads to new blood vessel formation in the front of the eye also, which leads to a type of glaucoma, which we call neovascular glaucoma. It used to be called rubiosis iridase. And this is a late-stage complication that usually has a poor outcome and poor prognosis as far as vision is concerned. The detachment I mentioned, when the blood vessels start to scar, they actually scar and start to pull on the retina and pull the retina away from the wall of the eye and cause a retinal detachment. And this usually requires surgery to correct. And then I mentioned diabetic macular edema, swelling in the retina. This is, again, another common cause of vision loss in diabetics. And what happens is those abnormal blood vessels we talked about, the microaneurysms that form, they're weak and they're delicate, and they can start to leak fluid into the retina, and that's how the retina gets swollen. And then over time, that fluid, as it starts to get reabsorbed by the body, leads to protein deposits in the retina, and so you get what we call hard exudates, and those can be damaging to the vision as well. So we now have pretty good treatment for all these aspects of diabetic retinopathy. We use lasers for certain stages and aspects of diabetic retinopathy, and we also do injections of medicine, which we'll get a lot more into a little bit later when we talk about macular degeneration, because it's a very similar type of treatment, but these injections help to treat all different aspects of diabetic retinopathy, and then, as I mentioned, some later stages require surgery to correct. But the most important part when we talk about treatment is to try to prevent the problem from getting there to begin with, right? So if you can avoid having these issues to begin with, then you're far better off than having to actually go in to get these treatments or surgeries to correct the problem. So it all starts from the primary prevention, which is controlling your blood sugar. That's by far the most important aspect of controlling diabetes and preventing diabetic retinopathy from forming to begin with. Along with that, blood pressure control is very important as well. That's just secondary to blood sugar control. Now, if you are diabetic and diagnosed, there are screening recommendations for getting your eyes checked. So you should get your exams done regularly to see if any of these problems are developing, because if we can identify earlier, issues, then maybe prevent them from developing into a much bigger problem. And then, of course, if you get to the point where there is a bigger problem, then we have treatments that can be done to help with those usually. So screening exams for type 1s are done initially 5 years after the first diagnosis and then annually thereafter. For type 2s, the first exam should be as soon as the diagnosis of diabetes is made. And then follow-up is determined based on whether there's any actual findings. If there's no retinopathy, then it's usually just an annual exam. If there is some amount of retinopathy, then you may be recommended to come back in 6 months or 3 months or 4 months, just depending on the severity. And then, of course, if there's a level of involvement where you actually need treatment, then treatment will be recommended. So these are just some of the treatments that I mentioned. There's a laser treatment that we do to target blood vessels, where we're essentially trying to cauterize all the leaking blood vessels. The injections of medicine that I mentioned, that we inject medicine directly into the eye to stop those blood vessels from leaking. And again, this is a very common procedure that we do. We'll talk about this a little bit more in detail with macular degeneration. This is done in the office. We stick the needle directly into the eye and inject medicine directly into the eye, as you can see here. And we have quite a few different options for treatment for diabetic retinopathy, different types of medications, including what we call anti-VEGF medications and steroid medications. And we know that anti-VEGF treatment is effective because the levels of this VEGF molecule are high in diabetics, and so lowering that level has been shown to be effective for treating the underlying condition. And then steroids are helpful because they stop inflammation, which is an important component of diabetic retinopathy. Now, people often ask, well, I've been told by my doctor to avoid steroids because I'm diabetic because it affects the blood sugars, and that's a valid point. However, when it comes to the eye, when we're treating the eye, the steroid is injected directly into the eye, and it generally does not have any effect on the blood sugar, so we often use this in diabetics safely without causing an effect on their blood sugars. And then, of course, surgical treatments, including what we call a vitrectomy, if there's bleeding in the eye, if there's a retinal detachment. So, and then I mentioned diabetic macular edema. The treatment for that generally is very responsive to the intravitreal injections of both anti-VEGF and steroids. So that's kind of an overview of diabetes, diabetic retinopathy, the treatments that we have available for diabetic retinopathy. Happy to take any questions about that subject matter, if there's anything. Yes, sir.
I've been given to understand that, have you guys ever heard of taurine, Taurine?
Yes.
That it may have some deficiencies in taurine can affect a lot of things, including the retina. Is there any accuracy to that?
So the question is taurine. Is there any evidence that deficiencies in taurine has some effect on the retina, outcome of the retina? There's no direct science or evidence that supports that. If that were the case, we would be recommending, some type of therapy targeted towards that. But there aren't any sort of direct clinical trials or things of that nature that suggest that that's the critical component of this. So could there be some truth to that? Maybe so, but it's never been supported by basic science.
There are some articles on PubMed on that.
Sure, but yes, but it's those may be at a level which don't lead to actual clinical support. So.
Well, clinical support is expensive, isn't it?
It can be, sure. Yeah.
And taurine is almost free, and nobody does studies on things.
That's very true. Yeah.
Okay, thank you.
Any other questions? Yes.
I had a question. You had a chart that showed an increase every 20 years.
Mm-hmm.
Is that because of population, or is there something that's causing that they have looking into?
Sure.
Research?
The question is, the prevalence of diabetes is increasing over time, and we had a chart that showed that the numbers, every 20 years or so, diabetics diagnosed with retinopathy is increasing as time goes on. And what do we owe that to? Why is that happening? Is it just because the population is growing? And yes, to some degree that is. We have, a slowly increasing population. A lot of it also has to do with there are more people just developing diabetes, and then it also has something to do with the fact that more people are getting attention or care and diagnosed. So of the population that may not have been aware of it or diagnosed with it, a lot more are going into the pool of being diagnosed. So it's a combination of different things, but in general, the numbers are increasing for even the existing population. So if you looked at a steady population and the number of people weren't increasing, the number of people with diabetes would still be increasing. Yes?
Just kind of a follow-on around the prevalence. I'm not sure how long the GLP-1s have been in the market, 5-6 years now.
About that, yeah.
But is there really an increase in diabetes because of that, or is that stabilizing and not increasing?
So the question is, we have this new classification of medication, newer classification of medication called the GLP-1s, which Ozempic and Mounjaro are part of that family. And how is that affecting the overall diabetic landscape? I think it's helping a lot of people control their diabetes much better. The numbers are still high, but a lot more people are able to achieve better control with those. But we haven't had them long enough to really know what the big impact is over many, many years. Because if they've only been around for, say, 6-7 years, then we don't really know sort of the long-term impact yet. I saw another hand over there. Yes?
Okay, if you go to the eye doctor, he can tell if you have diabetes, even if you don't know you have it.
So the question is, can you be diagnosed with diabetes from just going to get your eyes examined at the eye doctor's at an eye appointment? The question is, or the answer is maybe. So if you are diabetic and you've been diabetic for a while and you've gotten to the point where your body is starting to have complications, and we see something like little hemorrhages or other changes, or if you develop macular edema, then yes, you potentially can be diagnosed with diabetes just from that eye exam. And that does happen not too infrequently, where we see somebody and we say, hey, have you had your blood sugars checked? I haven't been to my doctor in 20 years. You need to go see your doctor because you probably have diabetes. That does happen somewhat regularly. That being said, you can't diagnose it just across the board for everyone just from an eye exam. You need to have the blood test. Your primary care needs to do all the evaluations to look at your blood sugars to really determine that diagnosis. Yes, but if you've gotten to the point where the eyes are starting to be affected, you can be diagnosed. Okay.
And we're now going to invite Dr. Rathod back to the stage, and he's going to talk to us all about macular degeneration.
Okay, so that video provided a nice overview of some of the things we're going to talk about in a little bit more detail here. So if you had any questions or comments about that, we can dive into that a little bit more here as well. So all about macular degeneration. So what is macular degeneration? Well, macular degeneration is a common degenerative chronic disorder of the retina that we don't fully understand the complete mechanism of what happens at the level of the cells, and generally affects older patients and features vision that affects your central vision. So that's just sort of the basics of what is macular degeneration. And this disease has been described for many years. The first associations between vision loss and having some disease or pathology of the macula was established sometime in the mid-1850s. So we've known about it for a long time. That's kind of when people were able to start examining the retina and knowing that we could actually look into the retina. There were diseases that affected the retina. So So this was described for many years. Obviously, the disease has been around for as long as we've been around, but we were able to tell that there was something around the mid-1850s, and then it wasn't until the 1980s that we were actually able to start developing treatments for the diseases that affect the retina. It is the most common cause of irreversible vision loss in Americans after the age of 60, and about 15 million Americans are affected to some degree with macular degeneration. So a lot of people have this disease. About 1 in 3 over the age of 70 has some degree of macular degeneration, and there's a new diagnosis made every 3 minutes, so you can see how common this is. And it has a huge impact on our society and the quality of life, especially for older folks. And as a lot of older patients say when they come into the office, they said, nobody told me that getting old was going to be so difficult, because you retire and you think you're going to enjoy the rest of your days, and you spend most of your time in your doctor's office. So we hear that all the time. So who gets AMD? Not to be the grim reaper of aging, but who gets AMD? So what are the risk factors for developing macular degeneration? Well, age, of course, is the primary factor, so this is primarily the disease of aging. A family history also is very important. If there's some family history, there's a strong genetic predisposition towards developing macular degeneration. So if your parents have macular degeneration, then you definitely need to be more conscious and aware that you are possibly going to have it. Modifiable risk factors, things that you can change. Smoking is one of the big risk factors, and that's the only one that we know of that's modifiable, that's under your control. And so if you are a smoker, you're much, much more likely to develop macular degeneration. And if you were going to develop it anyways, if you smoke, you're much more likely to develop the advanced forms of macular degeneration. There are also some looser associations with diets, blood pressure, and obesity, and those are also potential risk factors. So all the other things that affect your general health, because again that affects your circulation, your blood vessels, etc., that can also have an impact on macular degeneration. So what do you do if you have macular degeneration? So you have to seek care from an eye specialist if you're diagnosed with it. Ask for a referral for a special retina specialist. Because it's good to get an idea of what your baseline is. And I will warn that there are a lot of diseases out there that mimic or look like macular degeneration, but aren't necessarily actually macular degeneration, the age-related type. And so it's important to have somebody who knows what they're looking at, who has the tools to look at those things, to say, hey, this is actually typical macular degeneration and not something else, because that can mean a very different treatment plan if it is a different disease. So if you are diagnosed with any type of macular degeneration or macular disease, it's important to see the specialist to really get a sense of where you are, what your disease is, and what the prognosis and potential treatment options are going forward. Check your vision regularly, and that can be done in a number of ways. You saw one example from the video before. There are at-home monitoring devices that can help you with this. And then if you ever see any change in your vision, it could be subtle or dramatic, then it always warrants a visit to your eye doctor to have that evaluated to determine what's causing the change in vision. And so what does the effect of macular degeneration have on the vision? That was briefly talked about in the video, but it can just cause your vision to be blurry in general. You might see distortion, so straight lines might have a little waviness or crookedness to them. There may be parts of the lines missing. You might have little blind spots in your vision. Some of the other features that are subtle but people often describe is that you have harder time seeing in dim lighting, so you need adequate lighting to see properly. Transitioning from dark to light or light to dark, if you go inside from being outside for a while, or if you're inside and then you go out into the bright sunlight, that transition can take longer, can be a lot harder to make that transition. So those are some of the common features that we see with macular degeneration. And of course, this primarily affects the center of the vision. So this is the very most important part of your vision. It's where all the details are. And so this, obviously, if it starts to affect your central vision, can have a dramatic effect on your ability to function, your quality of life, reading, driving, etc., things that we do on a daily basis. And just a brief overview of what we're talking about. So this is a model of the eye, basically just showing all the different parts of the eye. The front of the eye here on the left, this is the cornea. This is the lens of the eye. This is where cataracts develop. This is the center cavity of the eye, the vitreous, and then the retina is the lining that lines the inner wall of the eye all the way back here. So this is all the retina. However, the macula, which is where macular degeneration affects, is just this very small part, and that's, again, your central vision, the most important part of all the details of things we see. So a very, very small segment of the retina and of the eye in general, which obviously is the most important part for your vision. So generally, we classify macular degeneration into two main categories, both historically and based on the physiology. And what was, we consider the two categories to be dry and wet. Those are the traditional names. We used to use dry and wet. You'll still hear those terms mentioned. However, we now prefer atrophic or non-exudative macular degeneration for the dry form and exudative or neovascular macular degeneration for the wet form. So those are more accurate descriptions of what's happening to cause these types of macular degeneration. So what we call the dry form or the non-neovascular, this is the more common form. So majority of people who have macular degeneration are in this dry category, anywhere from 85 to 90%. And basically this is when we start to see degeneration of the retinal cells. The hallmark of this being those deposits, those drusen deposits, and those are little yellow deposits that develop under the retina that can only be detected if you have an exam. But that is the hallmark of age-related macular degeneration. And the dry form generally tends to progress very slowly. For the most part, most cases, it's a very slow, gradual progression. In very early stages, you may not even know about it, and so that's why you need to get your eyes examined, because you may be developing these drusen and you may not even be aware of it because it doesn't impact your vision in the very early stages. Wet macular degeneration, about 10% of people have the wet or neovascular form of macular degeneration. This can develop very slowly also, but oftentimes there's a sort of a sudden change in vision where you start to see distortion or waviness, and that's where some of the home monitoring things can be helpful to detect that. And why is it called wet? What does that mean? Well, wet means that there's fluid or blood actually leaking and developing under the retina. And so that's why we call it wet. But neovascular is the term we like to use because that means that there's blood vessels growing where there shouldn't be, and those blood vessels are leaking fluid and proteins and blood into the retina, which is what causes the vision loss. So let's talk about treatment. So unfortunately, the bad news is there's no actual cure for macular degeneration. So when people ask about a cure, there's technically no cure for macular degeneration. But the good news is that we have a lot of good treatments to control certain aspects of the disease process. And this is all, the other good news is that this is a very, very, very active area of research. There are a lot of folks looking into newer treatments, better treatments, more effective treatments for controlling the disease. Just a brief mention of some of the older treatments before we get into the newer treatments. We used to traditionally do different types of lasers for the wet macular degeneration. There's a thermal laser and a cold laser. We still use these sometimes, but the majority of the times for macular degeneration specifically, the lasers are not used. So a lot of people ask, hey, is this treatment for this a laser treatment? And again, in some situations we may use lasers, but that's generally the older treatment. And for wet macular degeneration and the newer dry forms of macular degeneration, we don't use this treatment anymore. So what is the current treatment? Well, first of all, before we get into what we do when we come into the office and get our treatments in the office, what can you be doing yourself at home beforehand? And it starts with all the things that we generally recommend for good health. So eating a healthy diet, avoiding all the high-fat, high-processed foods. So eliminating those is important. Eating green leafy vegetables, things that are high in antioxidants and nutrients that are good for not only your eyes but your health in general. Exercise is very important also. You hear the recommendations to do at least 30 minutes of, even if it's just walking every day, to maintain some sort of cardiovascular health. That's also important for your eyes and macular degeneration. And then, of course, we talk about smoking. Smoking being the main modifiable risk factor that we know has a direct correlation with the severity and progression of macular degeneration. So, if you smoke, you've heard it over and over again, don't smoke. It's also important to protect your eyes from UV light. So, if you are outside for extended periods of time, you should wear eye protection that protects both UVA and UVB light. Most often nowadays there will be a label, a sticker on you that says UVA, UVB protection. But that's the most important part of having some type of eye protection when you're out in the sun. People ask about polarization. Is that better to have polarized lenses? Not necessarily. Polarization just means that light only comes in one angle rather than multiple different directions. That's helpful if you're out like on the water or out in the snow where there's a lot of reflection of light, but in general, otherwise you don't necessarily need polarization. For some people, polarization is actually worse because it blocks total amount of light, and it can actually make it harder to see in certain situations. So as long as it's UVA and UVB protected, that's the most important thing. So let's talk about what treatments we have for the wet or neovascular form of macular degeneration. And again, this is where we see leaking of fluid and blood out of the blood vessels into the retina, into the center part of the retina, causing vision loss. So intravitreal injections, where we inject medicine into the eye, this is the standard standard of treatment that we have for wet macular degeneration. It is by far across the board the most commonly performed procedure in all of medicine now, and I routinely do 30 to 40 injections every single day. So it's a very, very, very common thing that we do, again, it's in Medicare billing and in medicine across the board in the U.S., it's the most common procedure performed. We have a lot of options that we can use for treating macular degeneration. So these are all the medicines that we inject directly into the eyes. There's quite a few that have been approved. The very first one in 2004 was Macugen, and that one wasn't as effective, so it didn't really do that well, so we don't necessarily use that one anymore. But along the way, since 2006, that was when Lucentis or ranibizumab was approved, and we've had a few other options come along the way that have been approved for this treatment. We've had very effective treatment. Lucentis was the first one that was very, very effective in treating wet macular degeneration. 2011, we saw Eylea approved, and then there was one that got approved called Beovu, and very effective for treating it, but it also had some side effects that were undesirable. So that one has kind of fallen away, and we don't really use that one anymore. And then since then, we have what we call the third generation anti-VEGF medications, including Vabysmo and HD Eylea, which is just a high-dose form of the Eylea that was approved previously. Those are newer. We've had those for the last 3 to 4 years, and those are what we call the third generation medications, and those generally tend to have a little bit more effectiveness, maybe a little longer acting life cycle. So those are most often, if we have the option to, for the preferred treatments. So these are all the ones that are, again, FDA approved for treatment specifically for wet macular degeneration. So again, we have lots of options. We do have to mention Avastin, which is probably the most common one that we actually use across the board for treatment for macular degeneration. And the reason that this one gets its own category is because it's actually not technically FDA approved for wet macular degeneration, but we use it all the time. It's considered acceptable. Medicare considers it acceptable, and it is effective for treatment. It's just been around the longest, and its intention or its original approval was actually for cancer treatment. So when we use it, we're using it in a different manner. However, like I said, we use it so often and so frequently, and it's effective enough that it's considered still part of the treatment regimen and a very good treatment for wet macular degeneration. However, it has to be compounded by pharmacies when we use it, rather than getting it individually packaged for dosing for each individual patient. There are some other ones that have been approved more recently in the last couple of years, which we call biosimilars. And so this biosimilar category, not only in these retina treatments, but in many other aspects of medicine, are becoming very common as well. And biosimilars are basically molecules that are very similar to the original medication, only modified very slightly so that it's considered a different molecule, so then they can get separate FDA approval for it, but it often comes at a much lower price. And they generally tend to have similar effectiveness and safety profiles as the original medication. So we have about 5 different ones that are approved for Eylea, that are similar to Eylea, and then 2 that are similar to Lucentis. And so that may be an option for treatment as well. Those again are just as effective, except they're modified enough that they're given a different approval and a different pricing than the original medications. Surgical treatments, so there is a option as far as surgical intervention for wet macular degeneration. And this is something that we call a Susvimo port delivery system. And so what this is a refillable sustained delivery implant. And essentially, it's a little capsule or reservoir that holds medication in it, and this is surgically implanted into the wall of the eye, so it stays in the eye, and that little reservoir slowly delivers medication over an extended period of time. And when the medication runs out, it can be refilled again in the office, and so that's done just like an injection. So about every 6 months, this can be refilled with brand new medication. Again, this does require a surgical treatment, but this is also FDA approved for treatment for wet macular degeneration. And this is what it looks like. If you were to look at the eye, it's covered by the upper eyelid, so you don't necessarily see it all the time. If you were to look down, you might just see this little gray circle. That's the actual entry of the implant into the eye, and there's a little diaphragm on the surface which we can access with a needle in order to refill the reservoir when the medication runs out. All right, so we'll switch gears to the dry form of macular degeneration. So the main recommendations when you have dry macular degeneration, again, vitamin supplementation. You saw the video on one of the products that's available for vitamin supplementation, but that's generally recommended as important. And why do we recommend vitamin supplements for macular degeneration? The original study showed that it helped to reduce the risk of progressing to the more advanced stage. So it doesn't cure the disease. It doesn't stop it entirely. It's not going to necessarily make things better, although some people feel their vision does improve when they take the vitamins. But what the study had shown originally was that your risk of progressing to the more advanced stage is reduced by about 25%. So that's the intention of the vitamins. By reducing oxidative stress, etc., it may help to prevent cell damage, etc., that can lead to progressing to the more advanced stage. So that's why we recommend vitamins. And then we talked about healthy diet and UV protection as other parts of the treatment algorithm for dry macular degeneration. We'll mention one other modality of treatment, and this is something called photobiomodulation, and this is basically light therapy for the earlier stages of dry macular degeneration. And this is somewhat newer. It's been around for a while, but there was one device in the U.S. that just got it's FDA authorized. It's not approved, but it's authorized by the FDA for treatment for earlier stages of dry macular degeneration. And this is still in the very early sort of development and studies as far as the effectiveness. So it's not something that we are 100% recommending quite yet. It may be so in the near future that we do recommend this. However, we need more data and more time to see if this really truly is an effective treatment. And it's also currently not covered by any kind of insurance. So if we were to do this type of treatment, it's completely out of pocket as far as the payment for this treatment. So this may be something that does get incorporated into our practice and the recommendations in the near future. However, right now we're still waiting to have more data to support that it is actually something that's effective, because we don't want to necessarily recommend something and have folks pay for this treatment if it's really not going to be beneficial. So we want to make sure that it truly has some benefit before we recommend it. So you may have heard, especially with all the advertising on television, this concept of geographic atrophy. So geographic atrophy is a term or a subcategory of the dry macular degeneration. It is what we consider the advanced form of dry macular degeneration. And what does that mean? What happens in geographic atrophy? Well, basically, as your retina degenerates from the macular degeneration, the cells start to actually die away. So you have cell loss, and these cells start to lose their function and then eventually die. And once those cells are gone, you're left with a bare patch where there's no functioning retina. And as those patches grow, they turn into what these areas that we call geographic atrophy. And they can look like little stakes or maps, figures. That's why it's called geographic atrophy. And as I mentioned, this is considered a more advanced stage of dry macular degeneration. And now that folks are living longer, we're seeing a lot more people getting into this stage and developing these more advanced stages of even the dry macular degeneration. And this can lead to devastating vision loss, because once you get into this stage, it's permanent and there's really no going back. And this can have a huge impact on the quality of the vision, the ability to function, and how well you can read, how well you can see, how well you're sensitive to dim lighting. And so before a few years ago, we really couldn't do anything about this aspect of macular degeneration. Geographic atrophy just happened, and we had to watch it happen, and it progressed, and there was nothing we could do. So what I'll get into is that a few years ago, treatment was developed, but the important thing is, or the nice thing is that we have a robust pipeline of other treatments and medications that are being looked at. As I mentioned, macular degeneration is a very active area of research, and there are a lot of companies that have products that they're looking at for future treatments for this aspect of macular degeneration. What can you do besides the treatments in the office, which I'll get to, but supportive measures, we often recommend low vision evaluation. So if you've already gotten into that advanced stage and your vision is already somewhat compromised or affected, then there are magnifiers, there are other tools, having proper illumination as you're doing tasks, that you can use to help you manage or try to compensate for the deficiencies in your vision. And so generally we'll recommend a low vision evaluation, whether that may be with an optometrist that specifically focuses on low vision, and they can help you identify what tools might be most effective. The Braille Institute is another good resource that has things that they can offer you to see what might be helpful for you. I will mention one surgical device that's approved for advanced dry macular degeneration with geographic atrophy. This is an FDA-approved device. It's a surgically implanted telescopic lens that's placed in the eye at the time of cataract surgery. And this is called the implantable miniature telescope. And so basically it's a tiny little telescopic device, and what happens is that you have traditional cataract surgery where the cataract is removed from the eye, but rather than putting in a standard lens implant, as is the common procedure with cataract surgery, instead you have a telescopic lens put into the eye. And what that telescopic lens does is it projects whatever image is being viewed into a much larger territory on the retina. So you have to learn to use parts of the retina that aren't used for central vision because you've lost your central vision, and try to accommodate that image on the rest of the retina. So it does require a lot of training and adaptation, and it requires someone who's motivated and willing to be able to relearn how to see, basically, in order for this to be an effective device. But again, this requires that you have lost a lot of central vision from dry AMD, from the geographic atrophy, to qualify. And it currently also requires that you have not previously had cataract surgery, because it has to be done at the time of cataract surgery. In the future, it may be approved as a secondary implant where the existing implant can be removed and this can be put in its place, but currently has to be done at the time of cataract surgery. So then let's get into our newer treatments for dry macular degeneration. As I mentioned, about two and a half years ago now, we had 2 products come to market that are now approved for treatment for geographic atrophy related to dry macular degeneration. The 2 medications are called Syfovre and Izervay. And they work on a pathway called complement. And the complement pathway is a molecular pathway that leads to inflammation and cell damage in the body. This happens in all parts of the body, but in the retina, this is thought to be one of the underlying mechanisms for why there's cell death in geographic atrophy. So the first approved treatment was this medication called Syfovre, and it is FDA approved for treatment for geographic atrophy, and it's given as an injection, just like the other medications that we have, into the eye, and it can be done every 25 to 60 days. What's important to know about what does this treatment actually do for patients who have geographic atrophy? It doesn't stop it entirely, it doesn't reverse the changes, it doesn't improve the situation, it's intended to slow things down. So the best we have now is that we can actually potentially slow down the progression of geographic atrophy. So if we think that you're going to decline vision at a very rapid rate and you have a steep decline, this basically flattens the decline so that you decline at a much slower. It's still going to decline, however, at a much slower rate, anywhere between 18 and 43% slower. And so that can be significant because over time that's cumulative, and so this may prolong how long you have useful vision. The other one was approved about 6 months afterwards, was Izervay, and this one also shown to be effective for reducing progression of geographic atrophy. They're very similar molecules, work on the same pathway. This one is approved to be given has to be given every month, so the label says every month. So 2 medications, very similar. Is one better than the other? We don't know necessarily. One offers a better flexibility in terms of the labeling, and so it may have the same effectiveness at a less frequent dosing, so that there may be a slight advantage there. We did have, at our most recent retina meeting just last month in Long Beach, they did present 4 years of data on having this medication in clinical use, and the data is very positive and supportive of the fact that there's some continued advantage to having this treatment over a 4-year period that's sustained, that shows that there's a reduced progression in the geographic atrophy versus somebody who may not have had the treatment. So we have some continued evidence that things are looking good for these medications. And again, they're not perfect. They don't stop the disease. They don't reverse any changes. But before we had absolutely nothing, so now we actually have something that we can offer that can actually slow the progression of the disease. That being said, as I mentioned, it's a robust area of research. There are a lot of things in the pipelines, both for wet and dry macular degeneration, that are being looked at. We're looking at new targets, new molecules. We're looking at new delivery methods. Obviously, there's a big burden of having to come into the office, whether it's every month or even twice a month for some people, to get injections regularly on an ongoing basis. To come into the office, have your family members drive you, you have to get an injection in your eye, which, it's not painful because we numb up the eye really well, but there still can be some anxiety and discomfort with getting these injections over and over again. So is there a better way to deliver it? Can we do eye drops? Can we give you a pill? Is there some other longer-term delivery method where maybe you only have to get one injection and that lasts for 6 months? And that's why I mentioned that that's how the surgical implant was developed, because that was a sustained delivery device thought to be better for long-term delivery. So there's one mechanism of potentially delivering medication over an extended period of time. So that's kind of the things that research is looking for newer treatments for the wet macular degeneration, because we already have very effective treatment. For dry macular degeneration, again, it's a very complex disease, and like I said, we don't fully understand everything that happens in developing macular degeneration, but some aspects of it we do understand, and that's why the two medications that I mentioned, Syfovre and Izervay, were developed, because they look at the complement pathway. But as you can see, there are numerous other targets that can be looked at for potential treatment that can offer some help in slowing the disease also. So this is just the sort of the breaking the ice as far as our ability to treat the dry aspect of macular degeneration, but there's going to be a lot of other molecules, a lot of other targets that are going to be looked at for slowing down dry macular degeneration. I will mention one other potential treatment that has some possible future benefit. So this is something called regenerative patch technology. This is for dry macular degeneration. And this is stem cell treatment. So this is, everyone asks, are stem cells being used or looked at? This is one of the types of treatment avenues for stem cells that are being looked at. And basically what this involves is a very thin patch of stem cells that are surgically implanted under the retina in the area of macular degeneration or geographic atrophy. And that's to help to support and regenerate the cells where they're already lost and dysfunctional. And so basically this little patch is less than the size of a penny, but it's placed through a surgical procedure directly underneath the retina, right in the macula. So that is something that has been developed, has been done in research, patients, but very early stages still, and so that may be something that we see approved in the future. For wet AMD, again, we need things that work better, work longer, and are easier to deliver. And so this is sort of just an idea of how many things are currently in the pipelines for development for wet macular degeneration. So again, lots of things being looked at, very active area. And of these, I would probably say that maybe one or two will actually reach approval. But the fact that there's so many things in the pipelines is, that's a good sign that it's a very active area and that we'll have better treatments in the future. Gene therapy is one of those things that's being looked at very closely. We're involved in a lot of these clinical trials as well. We do these in our locations. And gene therapy is basically, this is different than stem cell treatment. So basically gene therapy involves injecting some type of cells into the eye or under the retina, as it were, and those cells actually produce the medication from within the eye. So basically, instead of having to deliver the medication on a constant basis externally, you put the factory of medication production inside of the eye. So these cells actually constantly produce the medication and control the disease by having that medication produced within the eye. And so this is a very active area, and we have a few products that are getting closer to potentially being approved for this treatment. One is a surgical treatment where we actually surgically inject the cells underneath the retina, and then another is one is what we call a supracortical injection, where we do the injection around the eye, around the tissues of the eye, and then it kind of diffuses around to the retina. So there's different ways of delivering gene therapy, but that is a very promising aspect of treatment for macular degeneration as well. So just to summarize again, macular degeneration is a very common disease. It affects a lot of folks. It's a disease of aging, and over the last 20 years, we've had amazing advances in the treatments that we can offer. Before that, we couldn't really do a whole lot, and now we actually have things that we can do to help and slow down the progression of the disease. And as I mentioned, we have a lot of future hope that newer things will be forthcoming. So it's a great field to be in, and I love what I do. Happy to take care of all the patients that we get to help with these treatments, and hopefully, like I said, we have better things to offer in the future. So I'm happy to take any questions. Go ahead.
Are you familiar with the Volita?
Right, so the question is Volita. So I mentioned the photobiomodulation light therapy. That's specifically what that is. So Valeda is the one that has the approval, or FDA authorization for use of that device.
That's what you were talking about.
That's what I was talking about, yes, correct, yes. Yes. Yes.
Dr. Rathod, I have some brochures on the Valeda back here.
So yes, Donna has some information on that in the back as well, so, yes. And that company, Lunather, they actually got acquired by Alcon, which is another big ophthalmic company. They have a lot of pharmaceutical and surgical products in development. So with that support, we're hoping that they get more data and research, and then we see that become a bigger part of our treatment. Yes?
When you say surgery, do they go into the hospital or do they do it in the office?
So when I mentioned surgery, anything that I described that was an actual surgical treatment, like the Vimo implant or the implantable telescope, that is an actual surgical procedure where you have to go to an operating room, whether it's a hospital or a surgery center. It's not done in the office. Yeah. All the other treatments, the injections, the lasers, everything else is done in the office. Yes?
Is there a difference in the delivery of the basic ILEA or the ILEA HD, seeing the HD is 4 times the dosage? As a patient, would you feel any different in receiving that?
So the question is, we have 2 ILEA products. We have the original ILEA, which is 2 milligrams. We have the newer one, which is the HD ILEA, that's 8 milligrams. So it's 4 times the dose. Is there a difference that the patient experiences when getting the treatments? The answer is, for the most part, no. It is a slightly larger volume. So when we inject the original ILEA, it's 0.05 milliliters. The HD ILEA is 0.07 milliliters, so it's a very slightly larger volume. So some people might experience a little bit more pressure, a little bit more blurry vision afterwards, but generally most people don't notice any difference. Because it's still the same molecule, so most often again, people don't necessarily notice any difference. Now, the benefit of having a higher dose is that a higher dose may be a little bit more rapid in terms of how quickly it works, and then potentially last a little bit longer. The way the pharmacokinetics of the molecule in the eye, meaning how the molecule is processed in the eye, is that if you have 4 times the dose, then it's cleared at a much it's cleared at the same rate, but it lasts a lot longer because you have 4 times as much of the molecule. So the benefit in terms of treating the disease is that maybe it works a little bit faster and maybe it lasts a little bit longer. And that's not true for everyone, but there are some people that it actually does have that benefit for. Some people get ILEA and they only need treatments every 3 months or every 4 months, but they do well with just the regular ILEA. So it's individual. So as far as the patient, again, you can't say one thing across the board, but again, most people don't notice the difference as far as when they actually get the treatment. But for some patients, there may be a benefit in terms of treating the disease.
If there's a tendency for the eye pressure to go up with basic ILEA, would there be more of a tendency for eye pressure to raise at the time of injection with 4 times the dosage?
Yes. So, good question. Now, when we inject these medications into the eye pressure does go up temporarily. Generally with the ILEA, the 2 milligram, the original one, it's 0.05 milliliters. With that volume, the eye pressure does go up, but usually it's so minimal and so inconsequential that it self-regulates pretty quickly, and most people don't have any problems with the eye pressure after getting that. With the slightly higher volume of injection, the higher dose, it's 0.07 milliliters. So yes, the eye pressure does go up a little bit more, but most eyes, it is well tolerated and doesn't have any further effect on the vision and the function, even with a slightly higher eye pressure. The eye is usually able to regulate at that level pretty quickly still. Now, the treatments for dry macular degeneration, the Syfovre and the Izervay that we talked about, those are double the volume of the other medications that we generally give. So those are given as 0.1 milliliter volume. So the volume is higher. So when we do those, people then tend to have more effect on the eye pressure. So even that very, very slight difference can be a big difference. So in the dry macular degeneration ones, we more commonly see people will have blurry vision right afterwards, because that high eye pressure can temporarily cause some blurriness after the injection. So, but the 0.05 versus the 0.07, we generally don't see much of a difference. Yes.
So if someone has also glaucoma when they take Eylea HD, does that affect the glaucoma pressure and it dies out?
Yeah, so
maintain a higher.
So the question is, if somebody has glaucoma, and glaucoma is a separate disease, but glaucoma is sensitive or dependent on eye pressure, and so we have to factor that into account when we're treating these patients. So does the higher doses or the higher volume of the HD Eylea or one of the other medications have an effect? And the answer is we always factor that into account. So if someone has a severe glaucoma, advanced glaucoma, and their eye pressures are very sensitive, then we may take measures to help with that, whether it's putting in an additional drop before the injection to lower the eye pressure, or doing something right after the procedure to lower the pressure immediately after the procedure. For some glaucoma patients, for the newer treatments, I'll only do a half dose, the 0.05 milliliters, because we don't want to push their pressure really high, because it can cause damage. So it's on an individual basis. But if there is a diagnosis of glaucoma that exists along with the macular degeneration, and we're doing injections, we do absolutely take that into account, because it can have some impact.
So if you have that glaucoma implant for your glaucoma, does that have to be changed?
If you have a glaucoma implant, no, it does not have to be changed. It does not affect that. So, and if you have an implant, that can help to regulate the pressure as well right after an injection. So especially if it's one of the valve implants, the tube shunts, those can be very effective in helping to regulate the pressure after an injection.
Okay.
Is there any relationship between trigium and macular degeneration?
So the question is there any relationship between a pterygium? And a pterygium is basically a growth of tissue on the surface of the eye that's generally thought to be caused by sun and wind exposure. And is there any relation to that and macular degeneration? And the answer is no. It's a very different disease process, different condition. So. Yes?
Is there any connection with the macular bulge and macular degeneration, or two separate things?
So the question is there a connection between macular bulge and macular degeneration? So I'm not sure exactly what you're referring to with macular bulge, because that's not necessarily a term we use generally.
That's what my eye doctor says, the bulge behind and it's bulging out against the retina.
Okay. So I'm not sure the exact specific. That's not a common term that we use. If they're saying there's a bulge, you might have like what we call a pigment epithelial detachment, or something else causing the retina to be pushed out. But that's not a term that we commonly use to describe pathology. So I'm not sure exactly what the diagnosis is there.
Well, yeah, I've been treated for it, so.
Yes.
I've had injections for about 10 years now. Doing fine about it. I just wonder what kind of consequence would there be for all of those injections just in my own eye?
Sure, that's a great question there. The question is, if you are getting these injections over and over again on a monthly basis for many, many years, what is, or is there a consequence to getting those injections repeatedly, time and time again? And the answer is, in general, it's a very, safe prospect, and the eye can tolerate many injections without any negative consequences. Now, each time you get an injection, of course, there's a small risk of the common things that we worry about, including infection, bleeding, etc., the pressure issue with the glaucoma. Those are things that each individual injection is a potential risk factor. And it's not like there's any cumulative effect of that over time. Now, if we really look closely at the tissue where the injections are given, if you give it in the exact same area over and over again, then there can be a little bit of thinning of the sclera, which is the white wall of the eye, over time, but usually it's of no consequence. And the eye, the sclera is able to heal extremely quickly after the injection is given. It's a tiny needle, as you know, and so once the needle is injected, that hole generally closes almost immediately, and then the tissue heals pretty rapidly. And that tissue is such that it's able to withstand tolerate those kinds of injections over and over again. I have folks who have received over 100 injections in one eye, so you know, it's certainly, the eye is a very robust organ. Yes?
What is the predominance of both eyes having like AMD?
So the question is, what are the chances, or do both eyes generally have AMD if you're diagnosed? Well, the answer is if you have AMD, you have it in both eyes. And they could be at very different degrees or different levels, different stages, but yes, you have it in both eyes. Now, if you don't, if there's something that's really just only in one eye and there's absolutely nothing that's a completely normal other eye, then you have to think it's something else. And that's why I say it's always important to make sure you have somebody really scrutinize what the disease process is before you actually get the diagnosis, because it could have an impact on treatment and prognosis. Yes?
Is it a fact that taking cortisone, whether the medication can exacerbate macular degeneration?
So the question is there an association between any type of cortisone or steroid therapy and macular degeneration? And the answer is no, we don't have any association between steroid and cortisone and macular degeneration per se. We actually used to use it to treat it. In the early days, we would do a combination of these anti-VEGF and steroid treatments for macular degeneration when we would inject the medicine in the eye. But there's no association that actual steroid cortisone treatment causes the disease to get worse or creates the disease. There are other macular diseases that are potentially caused by steroids, but that's a totally different disease. Yes? Go ahead.
Okay. I have wet AMD for a few years. Yes. For UV protection, do you recommend any like specific sunglasses that could help? Because I wonder the effectiveness of the UV, even though it said the sticker says UV protection on the sunglasses sold $30 at TJ Maxx, you know, versus, for example, the
known brands or known
whatever.
Yeah.
So, or and the computer blue light, because I use computer all day long usually,
So the question is, for the UV aspect of eye protection, is there any specific brand or type of lens or glasses that we recommend? We have to assume that if they are able to put the label UVA, UVB protection, that it is actually valid. That being said, if you go with, you know, like a trusted brand like Oakley or Maui Jim, or those are some of the common ones, yes, and you know that they're going to probably adhere to better standards for making sure that the lenses have UV protection. But technically, if they are able to put that sticker or label on it, then they provided the proper UVA or UVB protection. So I can't say that there's any one particular brand or tech that we recommend, as long as it has the label that says UVA, UVB protection. But I'm sure if you stick with like a known brand, you know, one of the more common ones, they go through much more strict processes to make sure that they're meeting standards. The other question was about blue light. And obviously everyone's using screens and telephones and computers all day long nowadays. And so what's the deal with the blue light? So blue light has never technically been shown to cause any serious damage to the eye by extended exposure. Yes, your eyes can get fatigued, they can get tired, they can get more dry over time from extended blue light exposure, but it doesn't necessarily cause damage. So if you have macular degeneration, do you have to protect your eyes from blue light wearing screens? Technically, no, but it may be just helpful for comfort reasons to wear blue light protection. But we generally only recommend it. Some people wear it all day long, but that can also affect other things like circadian rhythms, etc. So we generally just recommend if you're going to use some kind of blue light protection, to only do it when you're specifically working on the screen or computer.
We are now going to invite Dr. Rathod up, and he's going to answer any further questions that you have. So if we think of anything that you want to ask him, ask now.
Do you use the Valida in your practice?
The question is, do we use the Galita light therapy in our practice? And currently, no, we are not using it yet. Like I said, until we have better supporting data to suggest that it's actually going to be beneficial, we're not going to make people spend their money on it. So, but that may be something coming in the future.
And second question, this four care home AMD monitoring program, does that need a prescription from the doctor?
The Foresight home monitoring system, yes, that does require a recommendation from your doctor. There are other systems out there too. That's the one that we heard about here today that has a separate device. We actually use one called Ramoni Health, which is something that can be done on an app on your phone or tablet, so it doesn't require a secondary device. So there are different options for at-home monitoring that are available out there. So just ask your doctor what the options are. But different practices will use different ones. Other questions? Wonderful. Well, thank you everyone for coming. It's been great spending this Saturday morning with you. Thank you for taking the time out. And thank you again to Donna and Dustin, the folks at the Macular Degeneration Association. If you have any questions about my practice, our group, again, we have a table in the back. Our marketing coordinators, Annie Domingos, you can answer any questions about our practice. And then if you have any questions about our research, the clinical trials we're in, then Marino Casiano is our head of our research department, and she can answer any questions for you about that. And of course, I'm happy to answer any questions as well. Thank you again, and have a wonderful day.
Thank you so much, Dr. Rathod. We hope you got a lot of information in today's program, and we hope to see you next time we're in town. And otherwise, have safe travels. If you do have any issues with your validation slip, there's a button on the exit machine that says call for help. Tell them you attended today's program, you stuck your validation card in and it didn't let you out, they'll open the gate for you automatically. But that's worst case scenario. They said that those cards work most of the time. So if you have your surveys, please feel free to turn them over to myself or to Donna in the back room. Again, those are front and back. So if you can make sure you fill that out completely, we greatly appreciate it, and have a wonderful rest of your day.